Murray, for everybody, um, who has sponsored a visiting professor every year now for several years. I have known Gordon, or at least known of him, for quite a long time. There is a competition at the American Heart Association called the CATS Prize, and every sort of budding physician scientist um, wants to ultimately win that prize. And I can remember as a fellow before starting my research years, Gordon was in it and actually won it, and this sort of inspired me. And then I actually ended up being in the CATS Prize at the end of my time. Unfortunately, my ending is not quite as illustrious as Gordon's, and I have a finalist plaque, not a winner plaque. Gordon has really been a leader in cardiology and electrophysiology. He has remained funded throughout his entire career and has been incredibly productive. He's currently the chief and director of the Division of Cardiology at Johns Hopkins University. He's the past president of our largest society, the American Heart Association. He served on numerous grant and editorial review boards, and we're very pleased that you could come and visit us and share both what's going on in his research, but also to spend time with our faculty and fellows. And so I'm looking forward to his talk this morning on sudden cardiac death, genetic determinants, and risk prediction. So thank you
very much. Rob, many thanks. And I can assure you, if you were in the competition with me, you would have won. And let me also thank Dr. Murray for supporting this lectureship and professorship visit. It's going to be a packed couple of days, but I think this is part of the lifeblood of university education, university medicine. And people like Dr. Murray who support this type of activity really make a great contribution, not only to a day like today, but in fostering career development of both junior and even more senior faculty members. We look forward to this when we have these types of events at Hopkins all the time. And I understand that Dr. Murray and I shared probably some decision making at similar times during our career. When I was looking for residency programs, I ranked UCSF #1, but University of Washington #2. Wouldn't have been disappointed at either place, but was fortunate to be a resident at UCSF. It's a little more crowded down there than up here. Maybe get a little bit less rain though. So what I'd like to do is talk about sudden cardiac death, and really this is a couplet, maybe a ventricular couplet, if you will, because I'll be giving cardiology grand rounds tomorrow, and I'll talk more about some functional changes in the heart that might predispose to sudden death. But what I'd like to talk about today is kind of the genetic soil in which both rare, inherited in a Mendelian fashion arrhythmias occur, and common variants in the genome that might predispose to the development of ventricular tachyarrhythmias that might cause sudden cardiac death. So this is an overview of what I'm going to talk about, a brief introduction, and I do this with trepidation here, where resuscitation and the treatment of cardiac arrest really has its home and birthplace, and there's an ongoing work in the genetics of sudden cardiac death that's really important. That's actually going on here in Seattle, but I'll do a little bit of that and then talk about genetics and genomics and sudden cardiac death risk prediction, some of the genetic determinants. I had the opportunity to sit on a writing group on how to manage patients who have these rare Mendelian syndromes. I'll talk about those briefly, and then I'll talk about some complex genetics of sudden cardiac death in the context of an ongoing clinical study that we have. So I like to show this slide because although one of the fellows yesterday reminded me that this decline in mortality from coronary heart disease is actually flattening now. Over the past several decades, we actually have enjoyed a reduction because of acute treatment and more management of risk factors of a decline in the mortality rate from coronary heart disease. The same cannot be said of sudden cardiac death. And I also like this slide because it reminds us that regardless of what the structural heart disease is, in the majority of cases, around 75% for sudden cardiac death, coronary heart disease is at the core. So if you want to think about any mechanism of sudden cardiac death, you need to consider whether or not that mechanism is a mechanism of the development of acute ischemia or chronic ischemia, and sudden death is a consequence of that. So Again, in order to study these types of things at the population level, it's important to understand what case definition is and what the true incidence of disease is. And in the sudden cardiac death world, I think you've gotten it right in Seattle. We haven't gotten it right in other places, where in fact, the definition of sudden cardiac death is often defined by death certificates. Death certificates, we know, both at the level of the national organizations like the American Heart Association or US government estimates, overestimate the true incidence, particularly of arrhythmic sudden death, but sudden death in general. And it's multi-source case control types of studies like that in the Seattle Emergency Rescue Database or the Oregon Sudden Unexplained Death Study that actually give us a better estimate of what the true rate of sudden cardiac death is annually in this country. And it's probably around 200,000 per year. Important to understand case definition so that when you're talking about sudden death, you're talking about what you think you're talking about. Other work, again, from here in Seattle, has actually pointed out the following issue relating to sudden cardiac death and out-of-hospital cardiac arrest. And this is data by Dr. Cobb and Kopass, and reminds us that over the course of the past several decades, the mechanism by which people suffer out-of-hospital cardiac arrest really has changed. And that change has resulted in a lower frequency of ventricular fibrillation documented in the field, which is perhaps the most treatable sudden cardiac death associated arrhythmia, at the expense of an increase in asystole and pulsus electrical activity as a cause of sudden cardiac death, far less treatable arrhythmias that are found in the field. So another thing that we need to keep in mind when we're considering sudden cardiac death and case definition. It's rare that any one feature will be a cause of a clinical outcome like cardiac arrest or any other complex manifestation of disease. We tend to think of this more as a kind of multi-hit development of disease, not unlike cancer, where there's a predisposition, genetic or otherwise. Then there's a development of an acquired abnormality, whether it's the development of structural heart disease, that increases that risk. And finally, on top of that, environmental factors which may serve as triggers in this fertile genetic and structural heart disease substrate that results in sudden cardiac death. What I'd like to do is focus on the piece that's part of the genetic predisposition for dying suddenly. Now, there are two ways to kind of think about how genetics might influence any phenotype underlying human disease. And the two broad categories are those changes in the genome that are rare, that are inherited in a Mendelian fashion, autosomal dominant, autosomal recessive, X-linked. They have very high penetrance, and they often encode changes in the coding region of proteins, which results in a large change in function of that protein. So these are rare problems, but they're informative problems because it can tell us about how a protein functions, they can tell us about mechanism, and they can identify pathways that are important in a particular phenotype. Much more commonly are complex genetics that are associated with common variants in the human genome that cumulatively predispose to the development of a risk for a particular phenotypic feature. These are usually changes that have incomplete penetrance, and more often than not, they don't change the amino acid sequence of a protein, but instead exist in a non-coding region, sometimes in a non-coding region that's associated with the level of, for example, expression of a particular protein. Well, how much of the genome is actually under the influence of such selective pressure? Turns out not very much. If one looks at the entire genome, perhaps under selective pressures, about perhaps 5%, 1.5% of that is coding, and the other 3.5% that's under selective pressure is assumed to be, but is likely to be regulatory in nature. So a very small amount of the human genome drives a lot of the genetic predisposition to a number of abnormalities. So what I'd like to talk a little bit about first are those rare inherited syndromes that produce sudden cardiac death. And again, these can be thought of in two very broad categories. Those are associated with autopsy-positive sudden cardiac death, things like cardiomyopathies, arrhythmogenic cardiomyopathy in particular, one that we've been interested in. And then those that are autopsy negative. And the autopsy negative causes of sudden cardiac death are often channelopathies. They're mutations that occur in ion channel genes that produce relatively profound changes in the function of those genes that lead to an increased risk of ventricular arrhythmias. Now, I'll focus on two, long QT syndrome and Brugada syndrome, and try and go through those relatively quickly. So what is the approach to a patient who's got an inherited or presumed to have an inherited arrhythmia? Well, I think the approach is, first of all, you're not addressing this problem in an individual, but instead you're addressing this problem in a family. And these are evaluations of families, not individuals. So history, and in family history, is critically important. The things that one looks for are symptoms such as palpitations, syncope, seizures, nocturnal agonal respirations. It's useful to know what the circumstances are of either a syncopal event or a cardiac event. And other pieces of the family history are important. Obviously, premature death is one, but things like stillbirth, sudden infant death syndrome, and unexplained accidents or motor vehicle accidents, for example, are important parts of the history. The physical examination for most cases of autopsy negative sudden cardiac death are to rule out other forms of cardiovascular disease or other diseases. But in patients who have some of these syndromes, inappropriate bradycardia is often present, and there are some syndromic features that are syndromes that actually have features that are associated with sudden cardiac death. Syndactyly, facial dysmorphism, and congenital heart disease is seen in one form of, in quotes, long QT syndrome called Tomaselli syndrome, short stature, hypertelorism, and skeletal muscle disease like periodic paralysis is seen in another form of repolarization abnormality, long QT syndrome called Anderson-to-Wheel syndrome. Perhaps one of the most inexpensive but most important tests that can be done in this setting is the electrocardiogram. It's invaluable not only to look at baseline intervals, but to look at how the ECG changes, for example, with exercise and with ambulation. Provocative testing may be important. And in the case of sudden cardiac death, the right precordial leads tend to be really pretty important. So, for example, in long QT syndrome, and this is long QT syndrome 1, which is associated with mutations in a potassium channel gene known as KCNQ1. The electrocardiogram has a stereotypic, although not absolute, appearance, where the QT interval is not only long, but the T wave is very broad-based. So there's a very short ST segment. This is characteristic of long QT1, long QT2, and 3, which are the three major varieties, have different electrocardiographic appearances. Long QT3, for example, which is the result of mutations in the voltage-dependent sodium channel, has a very different looking QT interval prolongation, where the ST segment is really quite long and the T wave isn't so wide. And I think one other thing that requires emphasis here is that different mutations in the same protein can cause completely different phenotypes. So, for example, the sodium channel contains mutations that can cause a lot of different phenotypes that are associated with or increase the risk for dying suddenly. So a different mutation in the same gene, SCN5A, creates an electrocardiographic appearance of something called Brugada syndrome, where you have coving, an elevation of the J point in the right precordial leads. And this is also associated with sudden death, but perhaps and likely by a different mechanism. So if one considers the inherited channelopathies and considers what constructs the ventricular action potential, this is really the result of the orchestrated activity of a number of different depolarizing and repolarizing ion channels. These are transmembrane proteins that open and close in response to changes in transmembrane voltage. When they are open or closed, they pass different ions with different selectivities and at different rates. So if one considers how you get to the point where your QT interval is prolonged as a result of prolongation of your ventricular action potential, there are a couple of things that can happen. The plateau of the action potential really is inscribed by or is maintained by activity of depolarizing currents. So any increase in the activity of a depolarizing current will prolong the action potential duration. For example, an increase in the sodium current will do that. Any reduction or loss of function of repolarizing currents, primarily potassium currents, will result in the same thing. That is, prolongation of the action potential duration and prolongation of the QT interval. This slide also emphasizes that different mutations in the same gene can have different functional effects on the channel protein and therefore produce different phenotypes. So again, what I'm going to talk about are the long QT syndrome and Brugada syndrome moving forward. So again, I had the opportunity to sit on a writing group that updated the guidelines for in the management, the diagnosis and management of inherited arrhythmias. And these were presented at the Heart Rhythm Society meeting in May. I think they're due to be published in final form in September. So long QT syndrome is probably the prototypic channelopathy and the most common of these diseases. And even here, it's not particularly common, but these ion channel diseases can produce many different types of manifestations, everything from cystic fibrosis to migraine to infantile hypoglycemia and to a number of different skeletal muscle diseases as well as febrile seizures. So long QT syndrome really has worldwide prevalence. There is some question about whether or not the incidence is lower in Africa and in African Americans. Perhaps the best data on the incidence come from studies in Italy where infants are actually screened electrocardiographically, and about 1 in 2,000 live births is associated with QT interval prolongation. Mutations in 43% and 29% respectively are associated with QT intervals that are long or not so long, 460 and 470 milliseconds. The prevalence of congenital long QT syndrome as assessed in adults is a little more difficult to sort out because there are a number of structural diseases of the heart that actually can produce reductions in repolarizing reserve and prolong the QT interval. Begs the question, what is the normal QT interval in an adult? This has been studied in a number of different populations. I'm showing you here a study of military recruits, so this is mostly men, 41,000 men. The mean QT interval is 394 milliseconds corrected for rate. It's interesting to note that if you have a QT interval that's 450 milliseconds, you're in the top 0.5 percentile as a man of the QT interval. So it's likely that you have a reduction in repolarizing reserve, and you may, in fact, have a mutation that causes long QT syndrome. So the clinical manifestations of this disease, when it's typical, are hard to miss. They include arrhythmias in the context of QT interval prolongation on the ECG, syncope, sudden cardiac arrest due to torsade de pointe, which is a polyform of polymorphic ventricular tachycardia, named so by Dessertin in the 1950s. But there are other arrhythmias that are actually harbingers of torsade de pointe. And in this case, there's something called persistent bigeminy, where there's a PVC in a bigeminal pattern, and that PVC results in an abnormality in the QT physiology of the subsequent beat after the pause, begetting another PVC. So you can see ambulatory electrocardiograms where people go for hours with persistent bigeminy. And that, in addition to macroscopic T wave alternans, a beat-to-beat change in the amplitude of the T wave or the shape of the T wave, are risk markers for development of arrhythmias in long QT syndrome. We'll also say that in some cases, the electrocardiogram is not abnormal. The QT interval is within the normal range in about a quarter of cases. And as I mentioned, other than QT prolongation, there are other features of the electrocardiogram that are important and that identify people who are at risk. The other thing that we see a lot in the inherited heart disease clinic is not so much patients with long QT syndrome, but family members of a proband. And again, this is part of the total evaluation of not only the patient, but the family for risk of developing these arrhythmias as a result of long QT. So again, the typical characteristic presentation is unmistakable. Rarely do we get the kind of characteristic presentation. So there's a scoring system that includes electrocardiographic features, clinical history, and family history that we use to decide whether or not somebody has long QT syndrome when there's some debate about it because the QT interval isn't particularly long, and the features that would definitively identify somebody with long QT syndrome are not present. So there's a lot of debate in these gray area cases, and again, as part of this multi-organizational consensus statement, we developed criteria for making the diagnosis and managing all of these syndromes, and I'll just go through some of this very briefly. So for the class one diagnostic criteria for diagnosing long QT syndrome is a score of greater than 3.5 on that previous table, or a pathogenic, since many people now get genetic testing, or so-called class 1 mutation in a long QT gene, or somebody who's got a rate-corrected QT interval in excess of 500 milliseconds on repeated electrocardiograms with no secondary cause for that QT interval prolongation. Class 2A, meaning this may be the diagnosis, is if the QT interval is a little bit shorter but still prolonged with no secondary cause. And again, A quarter of patients won't have a QT interval prolongation, but may manifest QT interval prolongation with provocative testing, and that may include things as simple as postural change during recovery from exercise or epinephrine infusion. But these really haven't been validated in population studies or in registries for making the diagnosis. One of the themes of these inherited diseases is the genetic heterogeneity. So there are at least, now this table's out of date because there are at least 13 different genes that have been identified that have been associated with long QT syndrome. The good news for the genetic testing world is that the majority of those people who are genotype positive for long QT syndrome have mutations in either one of these three genes. About 90% of the genotype positive patients who have long QT syndrome have mutations in one of these three genes. Now, the other thing to keep in mind is that there are many, many different mutations in these genes, such that these are considered so-called private mutations, meaning that virtually every family that you see has a different mutation. And that different mutation means that making generalizations about how these mutations are going to behave across families becomes a little bit more difficult. So again, just in the first three genes alone, about 700 different mutations have been described that have been associated with QT interval prolongation. There are a number of other diseases associated with reduced repolarization, long QT intervals, long action potentials that have been associated with a number of other diseases. These are relatively rare, less than 1% of the cases in all of these. And in fact, when we do genetic testing in a patient who we suspect has long QT syndrome based on clinical features, what we find is that it's probably more effective, since these genetic tests are done on looking for missense mutations, that is, changes in the amino acid sequence. It's more beneficial to actually look for genetic duplications and deletions rather than looking at all the rest of these genes for relatively rare mutations. So what about risk stratification? So as I mentioned, very long QT intervals are associated with worse outcome, macroscopic T-wave alternance, symptoms very early at age, less than 7 years. And cardiac events when on therapy, and therapy here means beta blockers for at least long QT1 and 2 and probably long QT3. Are there any circumstances where you can feel a little bit more comfortable about patients who actually have a mutation that causes long QT syndrome? Well, two circumstances. Silent mutation carriers with a normal QT are at low risk, and long QT1 asymptomatic men appear to be at lower risk throughout life. Women, regardless of age, tend to be at higher risk. They have reduced repolarizing reserve from the beginning, and this is one of those cardiovascular diseases, one of the few, where women are at higher risk than men. So there are genetic features that might predispose to risk. So rare, high-risk genetic variants are Javel-Lang-Nielsen syndrome, which is an autosomal recessive form. Most of these are dominant forms. And mutations in the calcium channel gene that cause Timothy syndrome are particularly malignant. There are some specific locations of mutations that might be associated with increased risk. And this is one of the virtues of genotyping, so you know where the mutation is. And that's shown in this study from the University of Rochester long QT registry. Again, in their study, 25% of patients had a normal QT interval, and this is in 3,300 patients, 552 families who are genotyped, and this is basically a meta-analysis of 7 different registries. So what are the risk features? If your QT interval is prolonged, you're at higher risk than if your QT interval is in the normal range, even if you have a mutation. And unaffected family members obviously have the lowest risk. The other thing that seems to predispose to risk are mutations in particular areas of the gene, particularly the regions where the ion-selective pore is formed. If you have a mutation there, your risk of developing, having a cardiac event is increased compared to other regions of the channel. So what do we advise for treating patients with long QT syndrome? So class 1 treatment includes things that should be done in everybody, and they are lifestyle, avoiding QT interval prolonging drugs, prompt treatment of intercurrent illnesses, particularly those that are associated with electrolyte abnormalities and those that are associated with dehydration. We advise no competitive, high-level competitive sports, but on the other hand, we don't want people to be completely sedentary because more common forms of cardiovascular disease will get them. Beta blockers for virtually everybody. I even put people on beta blockers who have long QT3. if they have a genetic mutation. And I'm pretty liberal about using beta blockers even in people who have a relatively normal QT interval. And certainly they should be used in patients that have symptoms that are thought to be secondary to ventricular arrhythmias. For those who can't take beta blockers or for whatever reason have had cardiac arrest and cannot have, like young children, an ICD implanted, left cervical sympathetic denervation can be done thoracoscopically and is a useful treatment in those folks. And obviously, survivors of cardiac arrest in this circumstance should have a defibrillator implanted. Treatments that might be useful are beta blockers in patients who have not so long a QT interval. A patient who's got a malignant family history and has a long QT, a very long QT, may benefit from an ICD. And if a patient has recurrent syncope on beta blockers and they're actually taking their drug, that's an indication for an ICD as well. Sympathetic denervation can also be used for breakthrough events with or without the presence of a defibrillator. One of the things you'd want to do is, if somebody's having recurrent events, to prevent multiple ICD firings. Sodium channel blockers haven't been tested in large numbers of patients, but have been considered to be adjunctive therapy for patients who have long QT3 due to mutations in the sodium channel gene. And defibrillator implantation is not indicated in asymptomatic patients with long QT syndrome. So invariably, when we see these folks, they're usually young people, and they're usually young people who are engaged in athletics. And the question always comes up, can they participate, or what can I do to get back on the athletic field? And there have been 2 studies that have addressed this, and there's another set of guidelines that are actually being developed now. The Bethesda Conference in 2005 and the European Society of Cardiology. So the Bethesda Conference was a little bit more liberal than the ESC and said symptoms or a QT interval greater than 472 milliseconds in males and 480 in females, or an ICD in place, which is kind of ironic, results in disqualification from doing competitive sports. The ESC was much more rigid. They said, if your QT interval is prolonged, we don't want you doing it. But obviously, this has been violated time and time again. And if one goes to YouTube and looks for sudden cardiac death, what you see is there are a number of soccer players in Europe who actually have defibrillators in place, who collapse on the field, get shocked, wake up, and asked to go back into the game. So obviously, I think we need to rethink this, and we need to rethink this and are doing so right now. And there'll be another set of guidelines, hopefully within the next year or so. So are there any data to guide us as to what might be safe for young people to do athletically? Well, there aren't many data, but one set of data from the Mayo Clinic looked at 130 long QT patients who, despite advice against, participated in competitive athletics. More women than men in this case. Diagnosis had been present for about 11 years. They competed in a number of sports at a number of different levels, high school, college, and even a couple of professional sports. And in fact, these were kids who, young people, some of whom, about a fifth of them, had ICDs in place. And there really weren't much in the way of events. So about 1 in 331 athlete years was associated with an event. And that event was either cardiac arrest. In this case, it wasn't. It was actually a defibrillator shock. But I think, so the idea here is that probably with fully informed patients, families, trainers, and the presence of an AED at all venues in which the sports are going on, and at all venues in which practices are going on, you probably can get away with, in some patients, actually having them compete in competitive sports. But everybody's got to understand that although the risk is rare, the risk is real, and the consequences are usually devastating. So let me just move to the second of the 2 Mendelian inherited diseases, and I'll go through this relatively quickly. Again, it stresses the importance of the right ventricular precordial leads and looking at the electrocardiogram in these folks. And this is in Brugada syndrome. So Brugada syndrome is really now, according to the new guidelines, a purely electrocardiographic diagnosis. And it has to do with changes in the balance of repolarizing currents, mostly in the right ventricle, that produce electrocardiographic abnormalities like those shown here, where there's a dramatic J-point elevation and coving of the ST segment. This has to do with the fact that, and why do you see it in the right ventricle? You see it in the right ventricle because there's a large amount of repolarizing potassium current called the transient outward current in the epicardium of the RV. If you have a loss of a counterbalancing depolarizing current, you can get large voltage gradients in the epicardium, and those large voltage gradients early during repolarization, or in fact late during depolarization, can create this coving of the ST segment. What this does is it really creates a variability in the action potential duration, and that variability in the action potential duration can predispose to something called phase 2 reentry, where part of the heart's recovered, another part hasn't. The part that's recovered can be reactivated by the part of the heart that's still electrically activated, or electrically depolarized. So that's thought to be the mechanistic basis of arrhythmias in Brugada syndrome. Again, this has actually been tougher than long QT syndrome because prediction of events in Brugada syndrome is even more difficult than long QT. And what the diagnostic criteria should be were also debated, and there's far fewer patients with Brugada than long QT syndrome. So the class 1 diagnostic criteria really we decided were going to be purely electrocardiographic. So there are different severities of electrocardiographic change. The so-called type 1 ECG change is shown here, where there's J-point elevation in at least one lead in the right ventricular precordium of at least 2 millimeters. And this can be in any of the right precordial leads in the typical orthodox positions for the electrocardiographic leads, or an interspace or two above. But if you have an electrocardiographic appearance like this, that is sufficient to diagnose Brugada syndrome. That doesn't mean that person's going to be at risk for developing an arrhythmia, just means that they have Brugada syndrome. So type 2A diagnostic criteria, this may be Brugada syndrome, is when you have a so-called type 2 ECG change, which means you have this saddleback deformity in more than one right ventricular lead. So a type 2 or a type 3 electrocardiographic segment, ECG segment elevation pattern in greater than one RV lead with a provocative testing with an antiarrhythmic drug that blocks sodium channels, creating a type 1 ECG response, is also one of the diagnostic criteria for Brugada syndrome. So this is a far bit rarer than long QT syndrome, perhaps 5 times as rare, if you will. In Northern Europe, it's really pretty uncommon. Worldwide, the prevalence is about 1 in 10,000, the estimate, although it may be substantially higher in Southeast Asia. In fact, in some places in Southeast Asia, it's the most common cause of sudden death in men less than 50 years of age. And it may be related, in some cases, to an Asian-specific polymorphism in the sodium channel gene, which harbors about 20 to 25% of the mutations that cause Brugada syndrome. And it's been known by a number of different names in different parts of Southeast Asia: Lai Tai, Bangungat, and Pokuri in Thailand, Philippines, and Japan, respectively. This disease, unlike many of the other heritable diseases, particularly long QT syndrome, really has a male predominance, and it's possibly related to differences in the counterbalancing current ITO in the right ventricular epicardium in men compared to women. So again, adult onset here. Interesting, you have the mutation since birth. Why don't you get symptoms till the 4th or 5th decade? Seems to me that there's another second hit that's required to actually make this arrhythmia manifest. The presentation usually is pretty dramatic and pretty severe. Syncope, sudden cardiac death, cardiac arrest, nocturnal agonal respiration. Most often these occur at rest, like long QT3, as opposed to long QT1 and 2. There are other electrocardiographic abnormalities that are typically present, including sinus node function, AV block, sometimes ventricular conduction delay, so there may be other cues. A fragmented QRS can also be seen. And there are a number of precipitants here that make the Brugada ECG and the risk of arrhythmia increased. So those include things like fever or vagatonic agents, beta blockers or alpha agonists, tricyclics, hypokalemia. Alcohol in particular is one that we see fairly frequently in cocaine. Again, about 15 to 30% of cases are the result of mutations in SCN5A, the sodium channel gene, and 80 different mutations have been described thus far associated with Brugada syndrome in this gene. And there's a large differential diagnosis that includes other heritable diseases, pericarditis, RV compression, and other right ventricular abnormalities, including various forms of right ventricular conduction delay can mimic this. Again, heterogeneity and lots of different mutations that can actually cause Brugada syndrome. Here, 11 different genetic loci or genes that have been associated with Brugada syndrome. many of which impact on the function of the depolarizing sodium current, but some are totally unrelated. We have had a long-standing interest in the sodium channel, and it really is quite a genetic landfill for lots of different diseases. There are literally almost 1,000 different mutations in the sodium channel gene that have been described that have been associated with one or another heritable arrhythmia, whether it's atrial fibrillation, conduction system disease, long QT syndrome, Brugada syndrome, and in some cases, dilated cardiomyopathy. We were particularly struck by one patient who we saw in clinic who had Brugada syndrome, who had syncope when shopping with his wife in the Amish country. I don't know whether or not the two were related. I don't know if that was stressful or not. But in any case, we found a mutation in the linker between the first and the second domain of this protein, and it actually changed a priming arginine to a histidine in a consensus phosphorylation site for protein kinase A in this protein. Then we looked in vitro to say, okay, can this channel segment be phosphorylated by pKa? And the mutation was R526H, and the phosphorylation site, 2 residues down, was a serine. If we mutated either of those two things and then treated that peptide with pKa, we could no longer get phosphorylation of that site. So it looked like at reasonable levels of the kinase, this was no longer a phosphorylatable protein. In addition, there were some trafficking problems with the gene shown in these neonatal right ventricular myocytes, where instead of getting to the membrane surface, a lot of the protein shown in yellow here was hung up in the perinuclear region. Well, what happens to the channel or the current itself? So if you look at and these are ionic currents that are elicited by depolarizing voltage steps for the wild type channel and the 2 different mutations, you can see there's a reduction in the level of the current itself. That probably is the result of the trafficking defect, and that alone probably isn't sufficient to cause arrhythmias. We asked the question whether or not there are other triggers that might further compromise the function of this channel in a real-life setting. One of the things is, for example, fever or increased stress can lead to an increase in reactive oxygen species. There are a number of reasons to think that this was an issue. And if you look at, in the presence of a change in the ratio of NAD to NADH, to change the cell to a more oxidizing environment, you don't see any change in the basal current, or you see a reduction in the current in all three different subtypes, in the mutants and in the wild type. One of the things that pKa phosphorylation can do under certain circumstances is increase the current density, and in doing so can counterbalance the effect of, for example, reactive oxygen stress on the reduction of the current. We see that in the wild type channel, but in fact, it's no longer present in the mutant channel. So we have a situation where under certain conditions of stress, current density goes down. That density is no longer able to be reversed by pKa phosphorylation. This may be, for example, the trigger in the setting of a reduced level of current in patients who have, this patient who has this particular mutation causing long QT, causing Brugada. So again, risk prediction is very difficult at the individual level. And for Brugada syndrome, it's been particularly difficult because we don't have, like the long QT syndrome, surrogates for increased risk, like the length of the QT or macroscopic T-wave alternans. Turns out that, the type 1 ECG puts you at risk, but even your risk with a type 1 ECG is not that great. So we've been trying to, through registries, figure out what are the things that might predispose to risk. And there are 2 big registries in Europe, the Finger Registry, which is a registry of 1,000 patients, all comers, kind of the proper age for onset, 45 years, mostly men. And the presentations here were really quite varied, 6% with cardiac arrest, 30% with syncope, and 64% were asymptomatic. And the event rates for somebody in their 40s was about 1% per year. They looked at a number of predictors of outcome and found that symptoms, how you presented, a spontaneous type 1 ECG were the only things that predicted subsequent events. The things it didn't predict were an electrophysiologic study, inducibility of ventricular arrhythmias. Your gender didn't matter. Your family history of sudden cardiac death didn't matter in this registry. And whether or not you had a mutation in the sodium channel gene or some other mutation didn't seem to matter either. In a smaller registry of patients who presented with no arrhythmias, so this is just looking at people who might be at risk, who you want to know about in the future, turns out that the same things were important: syncope, a spontaneous type 1 ECG, and an EP study of very short ventricular effective refractory period, as well as fractionation of the QRS duration, tended to be important in predicting risk in these folks. So what do we do for patients with Brugada syndrome? Well, there are lifestyle changes and avoiding medications that are listed in the website, brugadadrugs.org. Avoiding excessive intake of alcohol, prompt treatment of fevers are the conservative things that we recommend that everybody do. In this case, if patients are survivors of cardiac arrest, there's really no debate. You need an ICD. Things that can be useful in patients with Brugada syndrome are if you have syncope that's thought to be the result of a ventricular arrhythmia, an ICD. And there are other things that can be useful in treating acute presentations like VT storm, including a drug that we rarely use anymore, quinidine, might be useful in treating VT storm because it really does block that repolarizing potassium current really quite robustly. The other thing is we always reach for a beta blocker when we have somebody with lots of VT, for example, in the unit. This might be the circumstance where you don't want to do that. You actually want to reach for isoproterenol. ICD implantation may be useful, and this is hotly debated because we have two camps about this, inducibility of VT or VF in this circumstance, might be useful in patients with inducible VF. Quinidine, we wouldn't use in this country, but it's been used in other parts of the world in asymptomatic patients with a type 1 ECG to kind of correct that. And catheter ablation may be useful in patients who have Purkinje fiber triggers that produce this arrhythmias in Brugada. And again, like long QT syndrome, ICDs are not indicated in patients who are asymptomatic. So we talked about rare diseases and rare variants, and I'd like to spend the last 5 minutes or so talking about the common disease, common variant paradigm. Here, the changes in the genome really are ancient. Ancestry is common. The frequency is high, meaning greater than 1% of the population carries a genetic variant. The effect of that variant on the function of any given protein is really quite small. And it really doesn't cause disease, but in fact creates a situation of susceptibility. There are few alleles, unlike the dramatic number of rare mutations that cause long QT syndrome. And the way we discover these common variants that might be associated with a syndrome is not by linkage, classic genetic linkage analysis, but instead by something called association, where we take a population of patients, we look for their genotype over, for example, a large range of genes, and we try to associate particular genetic variants with a phenotype of interest. These are called genome-wide association studies, and now we can do them on literally millions of different genetic loci at one time. And that's a broad-based, unbiased way to look for variants in the genome. The other way is by a candidate gene approach. So if we have a particular phenotype of interest, and we know from pathophysiology that certain genes, proteins, and pathways might be involved, we might look at a specific set of candidate genes to try and define associations between variants in those genes and the phenotype of interest. And the other thing that's been done and is going to continue to be done in a bigger way are large-scale resequencing programs, where, in fact, as genetic sequencing becomes cheaper, more and more of us are going to have our entire genome sequenced. And that's a bioinformatics problem. But that being said, you'll have all of the information that you need, not just variants that might be close by a region that's associated with a disease. So when we do association testing, there are a number of different considerations when defining the experiment. Do you want to do a completely unbiased gene? In sudden cardiac death, you might want to do a candidate gene screen, looking at channels and transporters, calcium homeostasis, neurohumoral control of the heart, inflammation, thrombosis, coagulation, transcription, translation, or others. Obviously, we'd like to look at the phenotype of interest, sudden cardiac death or cardiac arrest. That's a problem for us. So endophenotypes are important tools for us to use. So rather than looking for patients who've died, we look for patients who have, for example, have abnormalities in their electrocardiogram that might be associated with a syndrome, either abnormal QT, QRS duration, and in patients who already have defibrillators in place, appropriate defibrillator shocks. So through funding from the Donald W. Reynolds Foundation, which is not the tobacco company, but it's actually the advertiser from Oklahoma, we were able to support a number of different studies looking at genome-wide association and trying to discover genes that might be associated with risk of sudden cardiac death. And this was done originally in the CORA cohort, which is basically the Bavarian Framingham study. And we did this a while ago when the density of genotyping was a little bit lower, and we did it in a staged fashion. So we did an unbiased scan of women at the extremes of the distribution of the QT interval to enrich for the phenotype of interest, that is QT interval prolongation, which we believed was a surrogate for sudden cardiac death. And we, in stages, we looked at greater numbers of women, and we actually defined a gene that was abnormal. This gene is called NOS1AP, nitric oxide synthase adapter protein 1. Once we defined variants that were associated with QT prolongation, we basically genotyped the entire cohort for variants in this particular gene. And we're able to find that this was highly associated, that variants in NOS1AP were highly associated with QT interval prolongation. Now, when you do this kind of thing, it is essential that you validate these findings in other studies. And we validated them in a number of studies and found a robust association of particular variants in NOS1AP with the QT interval. And in fact, there's biological plausibility here. We actually made a lentivirus and infected neonatal rat ventricular myocytes with the NOS1AP gene, which encodes a protein called capon, or the carboxy terminal PDZ ligand of neuronal NOS. We found that at the RNA level and at the protein level, it's expressed in cardiomyocytes. And when we overexpress this, we could influence the duration of optical action potential. So in neonatal rat ventricular myocytes, if we overexpress NOS1AP, we shorten the action potential duration. So obviously, NOS1AP was something that was associated with QT interval prolongation at certain variants in this gene. Obviously, that can't be the only common variant that's associated with changes in the QT interval. And we were involved in a consortium called the QT-SCD Consortium. And this QT-SCD Consortium genotyped about 30,000 different patients. These two consortia genotyped about 30,000 different patients. And these are Manhattan plots. What's plotted on the y-axis is the probability of an association with a phenotype of interest, in this case, the QT interval. And on the x-axis is the genetic location. The higher the skyscraper in the Manhattan plot, the stronger the association. And it turns out in both of these meta-analyses, NOS1AP is the most tightly associated variant or the variants in NOS1AP are the most tightly associated with the QT interval. And that's in two different studies. And reassuringly, there are a number of common variants that exist in other genes that we know contain rare mutations that produce these congenital inherited long QT syndromes, such as SCN5A and the potassium channel genes that we've talked about. So 10 different genes, which means 20 different alleles that are common. More than 1% of the population are associated with the QT interval. If we ask the question, what is the change in your QT interval depending upon the number of these risk alleles that you have, and plot this. So we plot here number of samples, and we plot the number of QT prolonging alleles, and then plot what the QT interval is itself. So the larger the number of these risk alleles that you have, the longer should be your QT interval. And in fact, robustly, very robustly, that's the case. But look at what the effect is. Here's the problem. We have a strong association, but a quantitative effect that's really quite small. For each allele, the QT prolongs about 1.5 milliseconds. So obviously, this alone is not sufficient to produce the risk of developing long QT, and would argue that maybe it's not producing sudden cardiac death at all, just some variation in long QT. And let's see, so we went ahead and actually looked in ERIC and CHS, two large community cohorts, for the association between variants in NOS1AP and not QT, but adjudicated sudden cardiac death, and found that at least at this one risk allele, if you were heterozygous for the major allele, your risk of dying suddenly was lowest. If you were heterozygous, you had an intermediate risk of dying suddenly, and your risk was highest if you had both risk alleles at this position. So, in fact, not only associated with QT prolongation, but also associated with risk of dying suddenly. Now, that's interesting, but it's a little more complicated than that, because there are a number of different variants in the gene, in the NOS1AP gene. And in fact, there are variants that actually, common variants, that increase the risk of dying suddenly, and there are variants that decrease the risk of dying suddenly. I actually think this adds strength to the notion that this is a real risk loci. If it were all in one direction, you might question it, but different variants at different positions can have different effects on the expression of the gene, and can basically diametrically in an opposite direction, change your risk of dying suddenly to increase or decrease. And that's true when after you adjust for the QT interval itself and after you adjust for traditional risk factors for coronary heart disease, such as cholesterol, blood pressure, et cetera, et cetera. It does mitigate the risk a little bit, but the risk is still there. So there's still a locus here, NOS1AP, that's associated with sudden death, independent of other risk factors for cardiovascular disease. We were interested and actually worked with Sumit Chugh and the Oregon SUD study to try and discover other alleles that might be associated with true risk of sudden cardiac death. And the Oregon SUD study is a population-based study of basically sudden cardiac death in the community. He was able to adjudicate 424 sudden cardiac deaths in patients with coronary disease, and we compared these to 226 controls with coronary disease, but no sudden cardiac death. Initially, we looked at, in an unbiased fashion, using a 500,000 SNP array, and we looked for variants that might be associated with sudden cardiac death, and we used the following criteria. It had to, the association had to be close to statistically significant. That is greater than a p-value of association of greater than 10 to the minus 4. There had to be multiple variants within the same gene that had the same association, and it had to be within 25 kilobases of a known gene. And the minor allele frequency of these genes had to behave in an orthodox fashion, and we used the Wellcome Trust Consortium to do that. We actually found a gene that was actually pretty interesting that we're following up on. It's called glypican-5. It's a heparan sulfate proteoglycan family member, and it's expressed both in the heart and in the vasculature. It itself has not been associated with any human disease, but other family members have. And in ischemia, it's been associated with vasculogenesis and angiogenesis. So again, this is another way to kind of get at this approach of using genetics to try and understand risk of sudden cardiac death. I will, for the sake of time, just briefly describe a study that we've done to look at long QT syndrome patients and look to see whether or not variants in NOS1AP actually modify the risk of developing arrhythmia in patients with genotyped long QT syndrome. And in fact, if one looks at a risk variant for QT prolongation in NOS1AP, you can see that when compared to a reference group, which is a male patient with long QT1 and a QT interval less than 500 milliseconds, if you had the risk allele in NOS1AP, the hazard ratio for developing a cardiac event in these other groups was substantially increased. So modification of the risk of patients with long QT syndrome is influenced by the allele that exists in NOS1AP. So let me finally say that we've tried to look at this in a population of patients that we've studied who have primary prevention ICDs. We now have 1,200 patients in this cohort. We actually enroll people who are getting a primary prevention ICD. We assess them at baseline with an MR and CT scan at 25%. Everybody gets a signal average ECG. Everybody gets a blood draw. Everybody gets a clinical evaluation. They're followed every 6 months. And at those 6-month intervals, they get the clinical evaluation and blood draw again for both proteomic and genetic testing. And when they have a firing of the ICD, that firing is adjudicated, and we assess whether or not that firing was appropriate. And we consider appropriate primary VT, rate greater than 180, or VF. This allows us to actually compare patients enrolled in this prospective registry to other patients who don't have a firing to those who, in fact, the red bars do have a firing. We can also compare patients to themselves over time. We've enrolled about 1,200 patients at 4 different centers. They're a fairly typical ICD cohort, mid-60s, mostly men, some smokers, diabetics. EFs are low. Ejection fractions are in the low 20%. Most of them have class 2 or class 3 heart failure symptoms. About half are ischemic. The other half are non-ischemic cardiomyopathies. And they're generally well-treated. Few are on antiarrhythmic drugs, most for AFib. Bad things happen to people who are sick. And in fact, there have been a number of adverse events, including deaths as well as appropriate shocks. And let me just summarize here by saying that, interestingly enough, the all-cause mortality rate over the first 7 years of this study is about 5.6% annualized. That's a little bit more than the annualized rate of appropriate ICD firings for this cohort. So this is a group that didn't have VT, that had heart failure, that actually has a higher rate of developing death as opposed to developing a first appropriate shock. So we did a genotyping study here and actually found none of the genes that had previously been associated with sudden cardiac death in this cohort, but it's highly selected. So let me just finish up by saying we've done a number of different studies in this population, including looking at protein biomarkers of risk, and found that there are markers of inflammation that have been associated with an adverse outcome in this group. And in fact, if we look at CRP and IL-6, a downstream pathway member of the HR-CRP pathway, if you in fact are in the upper quartile at baseline of these inflammatory biomarkers, your risk of all-cause mortality of dying suddenly is increased compared to those who are in the lower quartile. Also, your risk of developing an appropriate shock is increased. There are other biomarkers, such as TNF-alpha and proBNP, that are elevated only in that cohort of people who've had an increased risk of dying suddenly, but not appropriate shock. So you might say that somebody who comes to present for a primary prevention defibrillator who has an elevation in TNF-alpha or an elevation in some of these inflammatory biomarkers is likely to die, but is not likely to be benefited by a defibrillator. So you might, in fact, decide that somebody with this proteomic, for example, profile should not get a defibrillator as opposed to those who don't have elevations in these serum biomarkers. I think finally, any one of these markers, genetics, proteomics, alone is not going to be sufficient to identify people at risk. And what we have tried to do is to look at combinations of biomarkers, whether or not those biomarkers are imaging biomarkers, protein biomarkers, in and of themselves are not sufficient, but the power of risk prediction can be improved by looking at multiple biomarkers and, if you will, a surface of risk that's contributed to by a number of different features of that particular patient. And I think that's the way things are moving in the future. We're looking at kind of profiles of risk of patients to try and better predict who's at highest risk for dying suddenly. So let me stop and conclude, because I know you guys have a presentation to do, by saying that sudden cardiac death is really heterogeneous, and there are complex mechanisms that determine sudden cardiac death, both in the presence and absence of structural heart disease. There are genetic determinants for all the mechanisms that can be interrogated by modern genome science. The utility of genetics and risk stratification really depends upon the context. So genetics is very useful in Mendelian disease. Right now, it's not so useful, I don't believe, in complex acquired disease. And surrogates of risk, functional surrogates of risk that might imply a genetic change are very useful, such as the ECG and something more complex like an imaging feature like scar on cardiac MRI can be very useful in defining risk. So let me finish by acknowledging the people who actually did the work in cardiology, a number of folks working in the laboratory, and this was done in collaboration in the Reynolds Center with people like Joao Lima, Eduardo Marban, Bob Weiss, and Kathy Wu. We had help with the genetic work, particularly from Don Arking and Aravinda Chakravarti, and Linda Cow did a lot of the work in the genetic epidemiology as well. And I think this picture from the Spitzer Space Telescope has a message for us all. This is the DNA nebula. So looking out into space, there's a double helix, and there's probably a message there for all of us. So thank you for your attention. Sorry I ran over a little bit, and I'm happy to take any questions that you might have.
I'm the Chief Medicine Resident at the VA, and it's my privilege to be able to present the 29th Annual Paul B. Beeson Award. As many of you are well aware, Dr. Beeson was a distinguished professor of medicine at the VA from 1974 to 1979, and was well known for his exemplary teaching skills. And the Beeson Award is presented annually by the internal medicine residents to recognize outstanding clinical teaching by a faculty member who exemplifies scholarliness, humility, compassion, and integrity. I'd like to announce this year's winner is Associate Professor of Cardiology, Ted Gibbons.